the risk that you will get an overdose of myself, it will be my pleasure to go on with the interactive cases, but I would need to have the beamer, I believe, or yeah, he will do that, the main beamer, because it's a bit too small maybe on the... Okay, I start with the, yeah, good. The beamer is warming up because you're cooling down your room so heavily that beamers have to warm up. Okay, the sun is rising. Okay, I'd like to start with the first interactive case with a 50-year-old patient who has chest pain, which is atypical, totally atypical, since several years. He has a normal physical capacity, ejection fraction, which is pretty normal. He has some rheumatologic problems, and he has an ECG with a non-inferior repolarization abnormality, all this since years, atypical chest pain. He has a little bit of risk factors, hypertension, lipids, positive family history. His father had an infarction when he was 63 years old. 50 years is the patient. So my question to you is, in this situation, you would, first of all, reassure the patient, because basically he has nothing typical since many years, ECG, a little bit of change, rheumatologic disease. Or you would send the patient to invasive core angiography, certainly depends on the audience where I am, where I will see a minority or a majority, or you would investigate the patient non-invasively. Would like to vote, please start the vote, whether you would reassure the patient, send to invasive core angiography, or investigate non-invasively this 50-year-old gentleman with totally atypical chest pain since many years, ECG changes, 2 risk factors. Okay, we stop voting, we wait for the results, and let's have a look at it. Oh yes, you see it here. So you will investigate non-invasively 100%. That's amazing, because in the other audience 100% wanted to reassure the patient, because basically he has no risk of coronary artery disease, really. However, now his brother died 57 years of age 1 week ago, and well, probably needless to ask you what you would do now, because you already told me that you would all investigate non-invasively, so probably can skip this question. I don't think that you're going to change this, but if we do the non-invasive testing, which one in this situation would be your choice? Would it be a SPECT perfusion imaging? Would it be an MRI? Would it be either rather a stress echo or a CT core angiography or a calcium scoring? I'm not putting invasive core angiography here because you all said 100% that you wouldn't do that. Please, let's vote now for one of these 5 options. It's interesting that 100% wanted to investigate non-invasively. Most of my colleagues would have done nothing, unless then you hear that the brother has died. Okay, so the majority of you would go for a SPECT perfusion imaging, probably appropriate for Society of Nuclear Medicine. Stress echo, inappropriate for Society of Nuclear Medicine, but still a good answer. CT core angiography, an excellent answer, although probably not for Society of Nuclear Medicine. Calcium scoring, equally well represented. I think that's a good choice. Now, if you look at the guidelines, so this is an article on guidelines on the CT core angiography from our working group of cardiac CT and nuclear cardiology. We have summarized a little bit of the literature, and of course, most single-center studies have a very high positive, but particularly very high negative predictive value. So in that patient, we wanted to reassure him, and we thought that the negative predictive value, well, if you go back here, please tell me in this situation, if I may ask this question again, is that possible technically? If we go back to this, I would like to know from you which one of these tests has the highest negative predictive value. Is it SPECT? Is it MRI? Is it stress echo, CT angiography, or the calcium scoring? Please tell me what is the highest negative predictive value. Please vote. Same slide, yeah. Because this is the question here. The patient has almost no risk factor. We want to reassure him. Yeah. Okay, so now we vote on the highest negative predictive value. Which test has the highest negative predictive value? Please vote. And then we look at the results. Okay, so the negative predictive value of a SPECT, certainly in the Society of Nuclear Medicine we have all the experts, so you do it at the highest quality. Still, the highest negative predictive value is, and it's almost ranking at the same level, it's CT core angiography in this patient. Calcium scoring is an excellent alternative, but below 60 years of age, most lesions are not yet calcified, so young patients tend to have uncalcified lesions. The negative predictive value is by far highest with the CT angiography. It's 95% plus. That's why we did a CT angio on this patient. Thank you very much for revote, and it was perfectly normal. And that was the way to go, certainly in this patient. Now I have a second patient, male patient born in 1942. He is a 65-year-old at that time when he came, retired airline captain. He had a routine checkup due to non-coronary heart disease, and he has a stent in the LAD, and 6 months after stenting, the regulations, the international regulation for pilots requires that they redo a nuclear scan. He's asymptomatic. By the way, I see most of the pilots in Switzerland from the army and from the airlines, and all of them are asymptomatic. That's an interesting population. You know, they all fit to fly, never had chest pain, even when they have an infarction. Oh, I'm fine, I can fly. So he's asymptomatic, but forget about it. Is he fit for the mission as a pilot? So he got a nuclear scan. And as we can all see here, the IRNC is the iterative reconstructed non-corrected, and on the right side it's the same with attenuation correction, IRAC. And you see that we do have an apical stress-induced perfusion abnormality, which is there at stress but not addressed. I show you the CT in the angiographic view, which nicely depicts the stent in the LID. A little bit of calcification in the other, but really not very highly calcified at all for his age. That's pretty good. This is the LID stent. There is big discussions whether we can evaluate the stents with the CT angio. You can have a look at the cross-sectional picture of the stent. I don't know exactly whether you would dare to say anything about it. I am very restrictive with this, but if we look at this, then, well, we can see anatomically which artery serves which territory, and therefore my question for you, if you look at this picture once more and at the nuclear scanning here quickly, this is the nuclear scanning apical ischemia. The question is, the ischemia is caused by what? Is it caused by in-stent restenosis in the LAD, by a new stenosis in the LAD? There was no calcification in the other arteries, by the way, and no lesion visualized here. Or is it a problem with the first diagonal branch? What could cause the problem? Please vote on this question. In-stent restenosis in the LAD, new stenosis in the LAD, or any problem with the first diagonal? Okay, so 50% are in favor of an in-stent restenosis in the LAD. That was exactly what I thought as well when I looked at it, because it seems to be this territory. Let's have a quick look here. That's the hybrid picture, which we did. And with this hybrid picture, we can very nicely see that the LAD with the stent serves a territory which has no ischemia. But it's the diagonal branch which now is causing ischemia, which, by the way, wasn't there before, because the diagonal branch was overstented. That's one of the reasons why we shouldn't put too many stents. There is collateral damage, really. This is very well known. Sometimes they can go through the stent and reopen this artery. In this case, due to the acute angle, probably they told me that they couldn't do that. So this patient ends up with an ischemia in the diagonal branch, which cannot be treated by revascularization, but rather by medication. So that's the conclusion. No restenosis in the stent, apical ischemia due to overstented diagonal branch, no revascularization possible, no pilot license possible. He is now only a co-pilot and not a pilot anymore. My question now, what do you think now is the ischemia caused by? Is it in-stent restenosis in the LAD? Is it a new stenosis in the LAD? Or is it a problem with the first diagonal? Please vote. I'm anxious to see that there is any change in your evaluation. Fantastic. You saved my day, and also, maybe the day of the organizers. Let me know whether hybrid imaging has changed the diagnosis. Please vote 1 for yes, 2 for no, 3 for not sure. With this question, we test whether the organizing committee was inviting a cost-effective speaker, Not saying that this was cost-efficient, but maybe effective. Yes, okay, 78%. Congrats to the organizers. We go to the next patient. This was an impressive patient here, a male patient born in 1940. He came for colon cancer surgery, planned hemicolectomy, atrial fibrillation, otherwise asymptomatic, but physically not very active due to degenerative knee arthritis. His risk factors were nicotine, 30 pack years, not terribly much, but quite a lot, hypertension. He comes for preoperative risk evaluation. When I looked a bit closer at the chart, I saw that his blood pressure was well treated. He was not obese. And the question here is, what is your recommendation in such a patient? There are multiple possibilities. One is no further testing. He has no chest pain. Second is non-invasive testing or invasive angiography. Please vote on this. And then we will look at the results. Okay, so we're obviously in a non-invasive audience here, and we do further testing. We did a nuclear scan, and I have skipped some of the slides because this is the algorithm telling you how much the guidelines confuse people on what they should do. There is basically no prospective randomized trial telling you that you should do non-invasive testing before surgery. There isn't. Nevertheless, we do it, and there is at least one good reason. The patient will have to sign the form in my country and certainly in your countries that he is okay and accept the risk of the perioperative cardiac events. Now, how can he sign for this? He has to know. If he has to know, we have to know. And if we want to know, we have to test for it. And one of the tests is nuclear scanning. This is his nuclear perfusion scan. I have enlarged this, and also I have the polar plots. He has a 0 scan, a 0 score, and he has an excellent ejection fraction. And we do attenuation correction in every single patient, and we do it in a way that we can calculate the calcium score. We have validated that in about 6 years ago in the European JNM. So we do attenuation correction in every single patient. We have the calcium score, and this was his calcium score. It was very high. Was at that time the highest we ever had. My question now for you will be, based on your experience and also on your daily practice that you do in your hospital, what is your recommendation? Excellent ejection fraction, zero sound stress score. Do you ignore the calcium or do you do further testing? Please vote. Okay, so you do further testing. Is that what the majority is doing? Because usually the minority is doing this, but it's quite interesting. Now, if you look at the literature, there is a nice paper looking at rubidium PET-CT as perfusion, and they looked at whether those with normal perfusion but very high calcium score had a difference in outcomes. So those with a normal perfusion scan but a very high calcium score over 1,000 had a worse outcome than those patients with a lower calcium scoring. So my question, we quickly repeat, it confirms basically you, but let's quickly vote on this, whether you're still, as a majority, would further test, or whether this even grows as compared to before, because we have now a paper which really supports the case of calcium scoring. Also, there is no guidelines in the world telling that you should do this. Oh, we have now some people would ignore the calcium score, although that data has supported it. Now, let's have a look at this data here. Here we have another paper, SPECT perfusion, 2,000 patients, all with normal perfusion. Calcium score had no predictive value at all. No difference. So the message here from Dan Berman, forget about the calcium score, because they are all equal. If nuclear is normal, they're all fine. Can we quick retest here whether you now would ignore the calcium score, because there was no difference in outcome between those with and those without high calcium score, or whether you would do further testing? Okay, now 56% would ignore the calcium score. Remember this number? Okay, now if you look at the New England paper and the data, they say if you have more than 300 calcium score, your risk over the next 5 years to get a major coronary event, including infarction and death, is 7-fold increased. Quite impressive. And he had 5,000. So our recommendation was to do an invasive coronary angiography, but the patient was referred to surgery without coronary angiography, and the surgery went well. However, 12 hours postoperatively, the right cardiac failure, he had a right cardiac failure due to infarction and a cardiogenic shock. And he had an emergency angiography. Let's check whether the movie works for me. I just show you the right coronary artery because the patient was in extremis. He was intubated, he was, okay, this was, I show you the pictogram of his coronaries. He had a massive triple vessel disease. And he died 2 days later. My question is, who would ignore the calcium score and who would do further testing? Please vote again. So you were at ignore 56%, I believe. Oh, wow. So we change mind occasionally. Very good. That means we're able to learn, and I think that is flexibility. This was one patient. Now starting from this, what we did was for 5 years prospectively, we have sent all the patients with that constellation, normal perfusion scan, but calcium score over 1,000, they all were sent to the cath lab for 5 years. And at the end, we looked what happened. 75% have a coronary artery disease, and 60%, 65% got revascularization. Now it is standard in our institution, all those over 1,000 calcium score, even though they have a normal perfusion scan, we send them to the cath. I know that 25% will have no epicardial coronary lesions, I know that, but 75% more or less will have it, except for the patient with renal failure. In those specific patients, we are not quite sure whether this applies, and we will investigate this as well, because they have other kind of calcifications. That's quite interesting. So now let's have a look at this other mail, but the chairperson tell me when the time is running out, I will stop. But I saw that most went, so I maybe have a few more minutes. So 53-year-old male patient at the time when he came to us, one episode of non-angina chest pain, no history of infarction, no dyspnea, and the risk factor is positive family history and dyslipidemia. He has a third risk factor. His best friend is a professor of cardiovascular surgery. That's a risk factor because this guy is very active and sends them all to myself. He refers me all his friends. His resting ECG was normal and blood pressure was normal, and he's concerned about his risk and wants a CT angiography because his friend told him that I have the latest scanner generation all the time and we do fancy pictures. And you know, I like these patients if they have nothing, because I do quickly 3D reconstruction, call them and say, have a look, it's all fine. And then, oh my God, it's not all fine. There is calcifications. We need a little more time to evaluate. We will send you a report, and then the surgeon say, no, no, I want to see it right now. Tell me what you find. And that requires then a little bit of more evaluation, more dedicated analysis. You can probably see that there is a little bit of calcifications, a little bit here and there. And so if you move on in the angiographic, we're not using it in daily routine, but just to show you that on the right side black and on the left side white, these are the calcifications that are a little bit everywhere. I have here the LAD, MPR, the multiplanar reconstructions of the diagonal branch of the circumflex. Maybe this was too quick. The diagonal, it shows you some of them are probably eccentric, some are very difficult to be evaluated, just like this. Circumflex artery, probably eccentric lesions. The right cornea was a little bit difficult here for the image quality because of a little bit of motion. And the question is, which vessel has a significant stenosis? There is a lot of lesions here. Calcifications are lesions, then how narrow they are, another question. So which vessel has a significant stenosis, if any? Please vote on this. It could be LAD, could be none. It could be all or none, basically. LAD, none, LAD, diagonal, circumflex, right coronary, all vessels. There is no non-invasive choice here. Okay, none of the vessels. Oh, that's a very diplomatic approach. That's the non-invasive. That's a good point. The question is, how do you know that the lesions are not producing ischemia? Probably because he's asymptomatic. That's a good point. But if we see these lesions, we do a test. That's our SOP, and we did this nuclear scanning in this patient, and so my answer was, because there was no ischemia, what exactly the majority of the audience here found without doing a nuclear scan. Shame on you. You should do a nuclear scan. If you're a nuclear society, you have the nuclear eyes. So you spotted that there is no vessel which is causing any ischemia here. I have, I think I should stop here because the time is running out, right? 2 minutes? Okay, then a very quick one. Male patient, born 1962. He presented with recurrent episodes of chest discomfort and breathing distress at physical exercise. Has been a little bit of a smoker, and the bicycle stress was clinically positive at 100 watts, which is quite low, but no ST segment depression. And here he comes for a SPECT MPI. And what is your recommendation with this history? Would you do any of the tests, or would you do non-invasive testing or invasive testing? Let's have a quick look, because he has chest pain. Do we need an ischemia test if he has chest pain? Some people would send him to the CAT. We are in audience number 2, I guess. Yeah, non-invasive testing. Okay, we did a nuclear test in this patient, and I would ask, you know, the question could also come up whether we would like to see the calcium score, but I think we go ahead. I show you the pictures here, and you will tell me, as nuclear experts, whether you see a perfusion abnormality in this patient, which is reversible, which is true. Have a great look at it. This is now the attenuation corrected pictures. No big difference really. So what is your impression? Please let me know whether you think this is an irrelevant finding, no further testing needed, or mild ischemia and no further testing needed, or invasive testing required. Let's quickly vote on this. I wonder, what is your decision? Mild ischemia, no further testing. I think that could be a wise decision. However, if I have a 46-year-old patient, I would like to know his disease. Mild ischemia. The calcium score doesn't seem to be of interest to you, but we're not going to vote on that because we don't have the time. But his calcium score for his age, 401, was amazing, amazingly high. So the CT coronarography was also, by the way, requested. I did hide this for you, and I just want to show you the CT angio of this patient because it shows some interesting ectatic coronary arteries. And when we did the fusion in this patient, we could see that the under perfusion, the anterior ischemia matches exactly the territory served by this ectatic coronary artery, and it is not necessarily a surprise that this is causing an ischemia, because I can show you here, ectatic coronary arteries, they do affect the laminar flow and they cause turbulent flow, and that's why they're very frequently associated with ischemia, 75% incidence of ischemia. And the larger the ectatic segment, the more ischemia, and nitroglycerin aggravates the ischemia because you further dilate it and therefore you have even more turbulent flow, and you shouldn't do it. The definition is 1.5 to 2-fold luminal dilatation. This patient had fulfilled that definition, and I think we need to know that nitroglycerin aggravates the ischemia. The proof that the patient has ischemia is that you measure the lactate in the coronary sinus, and this has been done in a study. They have given nitroglycerin and the patient produced more lactate, and so that's the proof that if you further dilate, you produce even more ischemia. So this is not an ischemia that should be treated with anti-ischemic medication in the usual way with dilatation. It should be treated with beta blockers only, because that uses then less oxygen. So this was just a small selection of the cases. I thank you very much for your attention, and I pass the word to the next speaker.